First of all, I'm highly thankful to Honor of Town Society for giving me an opportunity to give my talk on topoguided LASIK, which is my approach to laser vision correction in borderline corneas. Whenever a patient of refractive surgery walks into a clinic, first of all, we should know the various selection criteria for the patient. So, patient of myopia can be treated by PRK up to -5 diopters. LASIK, we can treat up to -8 diopters. In hyperopic patients, we can treat up to +2.5 diopters by PRK, and by LASIK up to +4 diopter or spherical equivalent. In astigmatic patients, we can treat by PRK up to 2.5 diopter cylinder, and by LASIK up to 4 diopters of the cylinder. So various limitations of the laser vision correction are: center corneal thickness should be more than 470 microns for PRK. It should be more than 490 microns for cases for LASIK, and residual stromal thickness after PRK should be more than 400 microns with Epi-on and more than 300 microns for the LASIK patients. The refractive error we can treat -8 diopter spherical to +4 diopter spherical, and percentage tissue alteration should be less than 40%, and keratometry should be from 39 diopter to 48 diopters. So let's have a case study of a patient which entered into my clinic, which was a female, 24 years of age, which has the manifest refraction of -6 diopter spherical with -2 diopter cylinder at 180 degree, and the mean keratometry was 42.7 diopters, and pachymetry was 500 microns. I choose for a flap of 90 microns. So it was borderline cornea, but I can do it. How? What first was to which procedure to choose from? I prefer to choose LASIK, a thin flap LASIK with the LASIK or topoguidal LASIK laser over PRK. Why not PRK? It's just because of post-operative pain, the late visual recovery, and the risk of haze in high refractive errors. So should I go for a standard LASIK or topoguided LASIK? The important things to notice for the refractive patient: the residual stromal thickness after 90 to 100 microns of flap should be around 300 microns, and the patient should have a normal topography. In the standard treatment, the basis is based on the keratometry, the pachymetry, and the refractive prescription of the patient. It corrects the sphere and the cylinder component only, and it's a good option for patients having the normal topography. The TopoLine offers the unique capability that provides the surgeons a greater degree of individual personalization. This procedure is redefining the term, the quality of vision, proving that many patients experience better vision than they ever did with glasses or contact lenses. So topoguided treatment offers us a basket of choices. In topoguided LASIK, we can correct the refractive error based on the topography of the cornea, centering the ablation profile on the visual axis for the better visual recovery, and maintaining the asphyxia of the cornea along with the reduced depth of ablation. Otherwise, we can also have the smoothing procedure of the anterior corneal surface along with or without refractive error correction. So the principal elements for the topoguided LASIK is the assessment of topography and centering the ablation on the visual axis. So a topoguided platform provided by the ZEISS, it has three components. That is the Atlas Corneal Topographer, the CRS Master software, and we can do procedure on MEL 80 or MEL 90 excimer lasers. So the patient's eye is imaged and analyzed unique elevation points on the cornea on Atlas Topographer, and the Atlas data is sent to the CRS master to create a customized ablation profile, which allows the combination of standard and topographic laser surgery. So the preview on the topographic CRS master, that is the planning station, you can see a orange cross which depicts the pupillary center. It determines the center of the optical zone, and it represents the anatomical center. And the green cross represents the corneal apex position, and it's close to the visual axis, and it corresponds to the manifest refraction. The pupil to ring center distance represent topographically derived angle kappa. So in the treatment planning, that we import to the topography to the CRS master, enter the other parameters of the patients. The ablation, topoguided ablation principle is that the ablation starts from the highest point of the irregularity of the corneal surface. So important thing to notice for it, a perfect topographic measurement is a precondition for a successful topoguided laser treatment. Inaccurate or unreliable data from the topography will lead to an inaccurate treatment of the patient. So the excimer laser automatically adjusts the laser pulses to match topoguided planning software. And so what else we can do with the topoguided treatment? We can treat corneal irregularity, the optic zone enlargement, the decenter ablations, the flap complications, the corneal haze, and the irregular astigmatism. So the indication for the topography smooth is eyes that cannot be well corrected with the glasses or contact lenses and have irregularities and splittage in the corneal surface with inconsistent refraction. The ablation profile is based on the topography map only. It's a two-step approach, creating regular cornea. Later, we correct the refraction with standard SCA treatment with a higher safety and the predictability for the patient. So customization by topographic planning offers us a tissue-saving solution. The clearly reduced depth of the ablation is a major benefit, in particular also for the secondary treatments. So topographic treatment is a leap forward. Its proven clinical results show improvement in uncorrected visual acuity with the best corrected visual acuity and excellent visual acuity outcomes. The clinical results indicate statistically significant improvement in contrast sensitivity and improved control of low order aberrations and correcting the topographical irregularities. So in summary, the topography glasses, it provides us the correction of refractive error based on topography and the ablation of visual axis for the better visual quality. And it maintains this asphericity of cornea along with the reduced depth of ablation. And it provides us the smoothing of anterior corneal surface with or without the refractive error correction. And it is good for secondary treatment for decentered ablation, small optical zones, central islands, flap complications, the corneal hair, and the irregular astigmatism. Thank you.